Our last prominent and esteemed guest before our Q&A portion, before our question and answer portion, is an expert in hyperthermia oncology. She unveils groundbreaking insights into the application of modulated electro-hyperthermia, mainly for cervical cancer treatments. Her work is remarkable and mainly events in the ongoing journey to make oncothermia more accessible and transforming cervical cancer. Modulated electro-hyperthermia more than doubles 5-year disease-free cervical rates in advanced cervical cancer patients in South Africa. We now call on Dr. Carrie A. MINNAAR, PhD. Let's give her a round of applause.
Sure, what a day. I'm not sure that I can deliver as impressive a talk after all my colleagues gave such amazing talks. So well done to everyone. And thank you very much to the organizers, and thank you very much for the invitation. It's really an honor to be in your beautiful country. Thank you. Okay, so right, a little bit about me. My background is a radiation biologist. So in our lab, we study the effects of radiation on tissues, malignant and healthy tissues. And today I will be presenting results from a phase 3 randomized controlled trial that we've been conducting over the last 10 years. There we go. All right, so my talk will have an introduction into what we've been doing, why we've been doing it, the trial methodology, and of course the results and future perspectives. So in South Africa and sub-Saharan Africa, we have a really big problem with HIV incidence. And what we've seen in the lab, in the radiobiology lab, is that HIV-positive patients are more radio sensitive. In other words, they have more toxicity from radiation, but their tumors are more radio resistant. So we started looking at ways that we could sensitize their tumors specifically to radiation. And we decided to investigate cervical cancer. Cervical cancer is an AIDS-defining illness, so 50% of our cervical cancer patients were HIV positive, and this is why we chose this population. So back in 2013, we started looking at ways to sensitize tumors, and obviously hypothermia came up. So we started looking at heating and sensitizing tumors and how this actually works. What happens when you heat a tumor? You induce high vasodilation. Vasodilation has two benefits. Well, it increases the oxygen perfusion and it increases drug delivery. So when we're looking specifically at radiation, the oxygen perfusion is very important, because if we flood the tumor environment with oxygen, we increase the rate of reactive oxygen species formed post-irradiation, which means we increase the cell kill effect. But there's another benefit. Over and above increasing the indirect cell kill effect, we also slow down the repair mechanisms from DNA damage. This is because the specific pathways that are involved in repairing from DNA damage occur or function optimally in a hypoxic or an anoxic environment. So when we flood the environment with oxygen, we slow down the repair mechanisms. But it's a very fine line, the heating, the temperature, where we draw the line. We just want to dilate the vessels enough to increase the perfusion. If we increase the temperature too much, we cause vasoconstriction, and when that happens, we lose all of the benefits. We don't get oxygen delivery, we don't get drug delivery. We also suppress the immune function. So we need just a mild heating in order to sensitize the tumors. And if we can achieve this, then mild heat becomes an excellent radiosensitizer that increases cell damage and inhibits repair mechanisms. This is a study done by Prof. Lee in South Korea. So Prof. Lee took 20 cervical cancer patients, treated them all with modulated electro-hyperthermia, MEHT, and she monitored the temperature, the peri-tumor temperature, but also the perfusion in the tumors using a Doppler ultrasound. And what she showed was, although the temperature increases, it is correctly a very mild increase. So it increases by just under 2 degrees after an hour. Most importantly, the perfusion was significantly improved. So we've checked the heating box, and we started looking at other ways that we can sensitize the tumors. And my colleagues have spoken about the abscopal effect. So the abscopal effect, there's maybe a handful of cases that are published every year. It's a very uncommon effect, although we're all taught about it and we know that it happens. It's also very well accepted that it's an immune-mediated response to immunogenic cell death caused by radiation. So if we can potentiate the abscopal effect, improve that, this is another way to sensitize systemic disease to radiation. So we looked at modulated electro-hyperthermia. Modulated electro-hyperthermia, MEHT, is able to induce immunogenic cell death, and preclinical and clinical studies in murine samples have shown that this immunogenic cell death results in apoptosis, and when we have apoptosis, where we get the development of apoptotic bodies, and this genetic material in the apoptotic bodies can be presented to the immune system, and the immune system, the T cells, are then able to recognize and remember the cancer cells and mount an immune response. So we're getting an adaptive immune response. I know a lot of my colleagues have spoken about this in detail. Another point that helps promote the adaptive immune response is the release of membrane heat shock protein, specifically HSP70. When this is released from the intracellular environment to the membrane and then to the extracellular environment, it takes with it this genetic material as well. And these heat shock proteins are also taken up by the immune system, presented via the antigen-presenting cells to the immune system, and this triggers the maturation of the immune system so that it can further attack and identify the malignant cells. So here we go. We've checked box 2. This is the treatment we decided to investigate. So we started our trial in 2014. We enrolled 210 ladies. And we had, at a 5-year follow-up, we followed them up for 5 years post-treatment, and at 5 years, we had 99 and 98 ladies in the control and study group. So we had really good follow-up results, and we didn't have a lot of participants lost to follow-up. We've so far published our preliminary results in a few very esteemed journals, and we've also won a few awards for the results. We won an award from the International Clinical Hyperthermia Society, from ESHO, the European Society for Hyperthermic Oncology, and very prestigiously from ESTRO, the European Radiation Oncology Society. And we won that award in 2021, and we presented our final results at ESHO last month at ESTRO last month in May. Okay, so our sample, cervical cancer patients, we included HIV-positive patients, provided they had a CD4 count above 200, or they were on antiretroviral therapy, obviously because we didn't want them to be immune suppressed, in which case they wouldn't be able to receive chemotherapy. So back then, we used the most up-to-date staging guidelines, which is FIGO 2014, and the recommendations were abdominal pelvic ultrasound, chest CT, and examination. So that's the staging that we used, clinical staging. We did not at the time do CT or PET CT studies for staging. So participants were randomized to receive either chemoradiotherapy with or without hyperthermia, oncothermia, and we administered 50 grays external beam radiation, 3 doses of HDR brachytherapy, and cisplatin. Cisplatin was prescribed at a dose of 80 milligrams per square meter, 21 days apart. Okay. As I said, we didn't do any imaging studies to stage the ladies, but what we did have was funding for PET CT, but only for to evaluate tumor response. So all the ladies had a pre-staging PET CT, and again a PET CT at 6 months post-treatment, just to evaluate tumor response. We did not change the staging based on the PET-CT. We also evaluated quality of life, and we did a cost-effectiveness analysis. So we can't give a placebo in a situation like this, or it's very tricky to. So what we did instead is we blinded all the clinicians as to which group the patients were in, and the patients were all counseled not to reveal which group that they were in. So there were only 2 of us who knew until the end of the study which patient was in which group. The Oncothermia treatments were given twice a week, immediately before radiation. So the reason we chose to give it immediately before radiation is, remember, we wanted to flood the tumor with oxygen. So we treated with Oncothermia, immediately irradiated. And the damage done from radiation is in nanoseconds of irradiation. So as long as the tumor had oxygen in, at the time of irradiation, our theory is that the reactive oxygen species would go and do their work. We also know from the literature that oxygen perfusion remains for several hours post-heating, although the temperature returns to normal very quickly. So the repair processes from irradiation, from radiation damage, take about 2 hours, or happen for about 2 hours post-irradiation. So we know that the oxygen environment would be the tumor environment would still be rich in oxygen for 2 hours post-irradiation, further slowing down the repair mechanisms. Okay, now the results. So this is the exciting bit. We obviously looked at dose-limiting toxicities, and we did not see any dose-limiting toxicities from the Oncotherm treatments. We had 2 participants who had 2 small first-degree burns the size of a blister, and we had just under 10% of participants who had fibrosis in the adipose tissue. That's because in our population, we have a large population. So we had a significant number of women over 30 BMI. So a lot of obese patients. So that's why our burns to the adipose tissue are higher than other reported studies, because of the thick layers of adipose tissue. Other than that, we did not see any differences in early toxicity between the Oncotherm group and the control group. And in radiation oncology, you'll know that we look at acute and late toxicity. So we looked at late toxicity at 3 years, still no difference between the groups, and late toxicity at 5 years, still no difference between the groups. Okay, then local disease control at 6 months on the PET-CT was almost doubled in the Oncotherm group. So this started getting us very excited. And then we followed the ladies up for 2 years and then 3 years. And at both 2 years and 3 years, we saw a significant increase in survival, but not just survival. We saw an increase in disease-free survival. And this is very important because we don't always just want them to survive. We want them to survive well and be healthy and integrate back into society. So on that note, we also looked at quality of life, and this was measured at 6 weeks post-treatment, 3 months, 6 months, and 2 years post-treatment. And it was consistently higher in the ladies who had Oncotherm treatment. But what was very important is that at 2 years post-treatment, when we did the final quality of life evaluation, of the 11 points, the ladies in the Oncotherm group were significantly improved in 10 of the sections. So that's 10 out of 11 that they significantly reported better results. And this, it's obvious, if they're disease-free without extra toxicities, they're going to be feeling better. You know, they're integrating, they're working, they're happy, they're enjoying life. Then we looked at the cost-effectiveness analysis. This was very important because we conducted the study in a resource-constrained setting. So we wanted to show that the addition of this technology was not going to be more expensive or outside of the financial capabilities of the healthcare system. So when you do, we used a Markov model, and the results are divided into quadrants. You have more expensive, more effective, more expensive, less effective. You really don't want to be in that quadrant. Less expensive, less effective, less expensive, more effective. So that's the quadrant you want to be in. And it's almost impossible nowadays with new oncology drugs to get into that quadrant because everything is so expensive. We fell into that quadrant with an 82% probability. So So we showed that the addition of this simple little treatment to our standard protocols was more effective clinically and had the potential to save the healthcare system money. This was because there's less recurrences, but also we can push more people through the system. So every public healthcare system really should be considering this technology. And finally, our 5-year results. So when we looked at the 5-year overall survival results, they were significantly improved in the ladies with stage 3 disease. However, when we looked at disease-free survival, it didn't matter what stage of disease they were in, the results were significantly improved. So we significantly improved 5-year disease-free survival rates. But not just improved it, we more than doubled it. So in a setting, we look at, in our setting, we look at something called a prescribed minimum benefit, which is something that everybody has the right to access in healthcare. And our prescribed minimum benefit is that if a treatment increases 5-year survival by 10% in oncology, then it has to be accepted. So this is, I mean, we've increased disease-free survival by more than 210%. This far exceeds anybody's expectations. So we're very excited about this, and we're very excited about reaching a point where we can include this treatment for cervical cancer patients. As I said, we have a huge problem with cervical cancer, and I believe in the Philippines, I think you have about 8,000 new cases per year, and your mortality rate is about 50%, which is the same as what we have. So I can absolutely encourage you and implore you to consider this treatment as standard of care for your cervical cancer patients. Then, and this is the most exciting and the most interesting part of our trial. Remember I said we evaluated participants with a PET-CT, but only for disease response. So what we saw on those pre-treatment PET-CTs, in 108 ladies, they actually had extrapelvic disease. We didn't change the staging because we wanted to see, first of all, it wasn't part of the protocols, and we wanted to see how the patients went through the workflow with the current staging or the standard staging techniques that we used. So we did a sub-analysis of these ladies. We had 54 women in each group with extrapelvic nodal disease, and they were treated only to the pelvis with radiation and oncothermia, and some of them had cisplatin. And we saw in a quarter of the women who had extrapelvic nodal disease and were treated with oncothermia, they had complete metabolic response of all disease inside the pelvis and outside the pelvis. So this was fantastic. And we ran a multivariate analysis and showed that this result was not associated with the number of cisplatin doses, because obviously you think, well, it must have been the cisplatin, systemic response. But not all the women had cisplatin. That was also interesting. Some of them developed renal nephrosis or hydronephrosis before treatment, so they couldn't have any chemotherapy. It was also not associated with a CD4 count, or their age or stage of disease. Well, obviously stage of disease, they're all in the same stage. But what was very interesting is it wasn't associated with their HIV status. So even the women who were potentially immune compromised could still have this immune response. So what we believe we've seen is a systemic response to a local treatment promoted or potentiated by modulated electro-hyperthermia. And at 5 years, every single one of those women was still disease-free, except for 2 who died from completely unrelated causes. Pardon? Oh, sorry. Oh, thank you. Yeah, so we believe that we've seen these very advanced stage 4B disease patients be cured with a local treatment, an affordable and safe treatment. This is a bit of a diagram that we've published in Cells, explaining how we believe this abscopal response is developed. We have the thermal effect and the non-thermal effect. Both have been discussed in detail in the talks by my colleagues. But the thermal effect, we know, improves oxygen delivery, improves reactive oxygen species, and inhibits the repair mechanisms. Then the non-thermal effect damages the cell membrane, releases the heat shock proteins into the extracellular matrix and promotes apoptosis, which releases the apoptotic bodies and in turn trains the immune system to identify and attack further cells with the same genetic material. So our conclusion is that the addition of Oncothermia to chemoradiotherapy for locally advanced cervical cancer patients significantly improves, in fact, more than doubles 5-year disease-free survival rates, safely improving quality of life and lowering treatment costs on a public healthcare system. And finally, it promotes a systemic, long-term, sustained immune response post-radiation. So future perspectives. Obviously, the 3 pillars historically for the management of cancer have been surgery, radiotherapy, chemotherapy, more recently immunotherapy. We strongly believe that Oncothermia should now be added as the 5th pillar for the management of cancer. So I would like to thank you all for your time. And again, thank you to the organizers. Thank you for the invitation. And I wish you all a very lovely evening.
Another extraordinary deliberation by the doctor. Let's give her another round of applause, please.